Thanks, Daryl, and I'm very grateful for the organisers to invite me to talk. I have been knee-deep in implementation of programs for quite some time, and I thought some of the learnings over the past couple of decades has certainly come to fruition in how we are actually rolling out the Think Sepsis Act Fast program. So really, to hone in, this was actually about implementation. This is a pragmatic approach about how to engage all clinicians in a hospital setting to ensure that they understand how to recognise and to resuscitate and to refer patients. So we have definitely adopted the elements of the Sepsis Kills program in New South Wales was at the starting point for what we have been doing, and I think those principles are incredibly important. We've also taken the approach that we recognise that despite all the new sepsis clinical criteria, our work started way back in 2012, and we have recognised the importance of having and continuing to use early warning criteria to predict future sepsis complications for patients, as well as recognising the need to identify those patients with severe sepsis. One of the key elements of success for me has been the engagement of nursing staff. Nursing staff have a particular role in hospitals. They are the coordinators of patient care, and they need to be fully across sepsis clinical pathways. That ownership has led to rapid adoption in the hospitals that we've been doing the pathway. While we know that most sepsis comes through ED, 20% still occur up on the wards. And so that pathway from the patient from ED into the wards and into ICU and backwards and all over the place needs to be recognised. Patients also get admitted in many hospitals in all sorts of places. So my original work at Petermac, we had no ED, as you know. And so patients could present with sepsis in outpatients through CDU, be directly transferred into the ward. And I still recall a patient with gluteal necrotising fasciitis, a young girl who was transferred from a peripheral hospital with a systolic blood pressure of 70, and shortly around the time we launched the sepsis pathway, and I'm sure she's alive today because of the rapid response at the time. Good handover has been one of the reasons why we've chosen to develop a clinical pathway, and also to support antimicrobial stewardship. There is a lot of anxiety around overdiagnosis of sepsis, overtreatment, more use of broad-spectrum antibiotics. And in fact, we've shown the opposite with this pathway, with a shorter duration of intravenous antibiotics, early oral switch, and be able to reduce overall antibiotic use and to reduce the use of unnecessary meropenem and vancomycin. And of course, we need to make sure that we support existing hospital processes and not put something that's too different. This is just published earlier this month. It is free online, so everything in the paper is available for you to see, including the 3 PDF versions of the pathways across the inception from 2013 through to the current pathway. And what you will find in there, because I could talk about this for hours, is the way we measured and evaluated the process and the outcomes. The process mapping I wanted to just focus a minute on. What we mean by process mapping was actually to go down and observe what nurses, pharmacists and doctors and other staff were doing when a patient was septic. We identified very significant knowledge gaps in terms of understanding recognition of sepsis, the current clinical management. There were major structural barriers. There were often antibiotics not available. There were no rapid infusers. Often there were wards where there was only one nurse cannulator. If you don't have enough nurse cannulators, it's very hard in a hospital staffed by 2 residents overnight to actually get patients cannulated to have intravenous antibiotics if they're crashing. So this process mapping is fundamentally important when you're putting any clinical pathway in, to define those gaps and then systematically address those gaps right across the hospital, including right up in and engaging key clinicians, including the intensivists, into designing the pathway. And you can well imagine the much discussion that we had about how much fluid, which antibiotics, etc., etc., etc. But that is a process that you need to go to. So that multidisciplinary approach to developing the pathway is essential. Then comes the issues of sustainability and transferability. So sustainability is difficult because in our current health system, I don't think there are good funding models to support quality and safety. And it is a disappointing discussion to have with executives to say, well, we don't care that you reduce length of stay because the beds just get filled and it's a service to the community that you're saving lives, but you're not making money. Well, in actual fact, we did save money. So as part of the process, both for the Petermac pathway, and there will be a further publication shortly by Michelle, who's one of my PhD fellows, where we're doing formal cost effectiveness evaluation, and this was the short-term benefits of the pathway, which saved about $8,000 per patient put on the pathway, and that was a minimum. And in some of the surgical patients, saved around $30,000, particularly the complex colorectal. This type of work is very important for future planning, for implementation of programs. So this is what the program looks like. This is, of course, as you know, RMH is a little old on the old IT system, so we have a fully paper program, and I'll talk about the MR elements later. But the pathway not only includes the core elements, but also includes the empiric guidelines. We've included the empiric guidelines because everybody needs to know what the appropriate antibiotics are. You don't need to go to a second place. And this has meant that everyone understands the appropriate and most narrow spectrum or additional antibiotics required for particular indications. And that has created a lot of ownership, particularly with junior medical staff who often rotate in and out of the hospital into different areas. It's kind of Groundhog Day. But the staff that are there every day at the front line are the nursing staff, and they have particularly appreciated this element of the pathway. And it is also medical record, I should say. So at Petermac, for many years, the last page was an audit page which the nursing staff would partially fill out, and we use that as an audit tracker. That's gone on the current version, but the medical record staff particularly appreciate the fact that they have this document now to support their coding. Again, we could talk for hours on clinical criteria, but reminding you that when we developed the first pathway in 2012 with the old criteria, the key element I reinforce every single time I educate about sepsis, that the primary point is, does the patient have suspected or known infection? It's not just about it's not just about the SIRS criteria or the SOFA criteria. So the first element is known or suspected infection. We use the SIRS and we added in hypotension as a trigger for severe sepsis. We had a consensus approach across physicians, ED and ICU at the Royal Melbourne, and this of course was around the time when the updated criteria came, and we elected to of course retain the early warning criteria, which were demonstrated to be very important in our previous work, and we included signs of severe sepsis. As almost 100% of patients have elevated respiratory rate, we thought it was confusing to have a separate respiratory rate cutoff. And it had to be something that was pragmatic and meaningful, and this is what we have gone with the scale-up. You all know the key actions, but what I did want to make a point was that over my years of auditing patients with sepsis, it's bloody impossible to audit fluids. It's very difficult, particularly in paper records, and also oxygen. So with the scale-up, while we're measuring process measures and outcome measures, and there's very detailed data collection as part of this scale-up program, we are looking particularly at the blood cultures. We say 2 sets of blood cultures because the sensitivity and positivity is much higher with 2 sets. The measurement of lactate and the timing of antibiotics are the 3 process measures that are sort of easiest to measure. Again, one could talk for an hour about fluid management in sepsis, and I recognise and understand some of the controversies at the moment. And again, we have taken a fairly pragmatic approach in terms of initial rapid fluid boluses with the crystalloid, recognising that there are areas like ED and haematology oncology where they're comfortable and happy to give larger volumes. And I can tell you, in my years of auditing over probably 1,000 patients, the average volume, given wherever you measure, is about 500 mils. So despite the fact that the early sepsis pathways had 10 to 20 mils per kilo and then 1.5 or 2 litres, the residents still gave 500 mils. So it is actually very interesting when you actually out on the ground and see what's happening. Of course, the MET team and the ICU teams are obviously more comfortable giving larger volumes than the medical staff in the wards. I'm not going to spend too much time on this, but just to demonstrate the impact of the Royal Melbourne pathway, very similar results to Petermac in terms of reduction in mortality, ICU admission, length of stay, and time to antibiotics. And simply, I think, the raised awareness, early recognition, early appropriate therapy, and early resuscitation clearly makes a difference. And it was on this basis that the Better Care Victoria selected our program at Royal Melbourne to be scaled up. I just wanted to also highlight a couple of findings that we have seen, and one of them, the location of patients with sepsis, I think is quite interesting. So in the historical cohort, we're seeing a few more patients being identified with routine ops, that's even in ED as well as the wards. A few more patients under general during medical ward rounds and MET calls, and you've seen a shift away from patients developing sepsis in the wards, and that certainly was highlighted even with the Sepsis Kills work about missed patients going to the wards. So making effective recognition in ED will reduce the number of missed sepsis cases up on the ward. The other element obviously is the impact of triage, which really does have a huge impact on timeliness of antibiotics. And early on in the Royal Melbourne rollout, ED became quite stressed actually because there were many more patients that were needing to be started quickly and early. And we use that as an executive driver to help support resources in the ED to help move patients through a bit more. And it was a good way for the executive to recognise the importance of the pathway. But you can clearly see the reduction in time to antibiotics of patients on the pathway, particularly for Cat 1 and Cat 2. So the collaboration has been fantastic actually. The Better Care team really do support the programmatic elements of the implementation with direct support to all the sites, which allows me as a clinical lead and Kelly Sykes, our project officer, to really focus on the implementation of clinical aspects. And I think it has been an ideal model to do something like this. Our primary objectives, again, are similar to what we had at Royal Melbourne, to ensure adherence, to decrease the rate of mortality, reduce length of stay, but the secondary objectives such as reducing the time, improving appropriateness and engaging consumers, which has been a very important focus. These are the participating health services, and you can see there's a real mix of rural, regional and central Melbourne. And I have to do a shout out for the regional sites because they were just so ready to do this. They hadn't had toolkits and resources to do something like this, and they were much quicker to mobilise and get the program piloted and to roll out than the big Melbourne sites like the Alfred and the Western, who have to go through a number of hoops to actually mobilise and do something like this. And of course there's that intersection with many of the hospitals with the EMRs in progress as well. This is a timeline that's been set by Better Care Victoria, but just to highlight, it's pretty intensive. You know, they've only got just over a year to audit, baseline audit, pilot, adapt, get the pathway approved, piloted, and then to roll out and evaluate. And we're evaluating not only the process and outcome, but we're also doing a formal cost effectiveness evaluation as well. So it's pretty intense. But I guess the key elements here is that I strongly recommended for the rollout that there needed to be dedicated funding. You cannot do these things with existing staff or existing resources. So the collaboration provided funding for a full-time project officer, and the ideal type of project officers are senior nurses, ICU liaison nurses, those type of highly trained nurses, as well as a session for usually an ID physician, ED and sometimes ICU physician who've been supporting the rollout. And that has been absolutely critical to get things moving quickly. The other thing is to ensure that they have a well-represented sepsis working group in the hospital, good executive sponsorship, to work out which committees in their hospital, the optimal ones, to put their sepsis pathway through, to ensure that there's engagement right across the hospital, particularly a little bit harder in some of the surgical units, but generally speaking, it hasn't been a major barrier. And to do those things that we did and explained, and we have taught the sites to do that process, and it's been very revealing and important. And also we have supported the fact that they can actually locally modify their pathway. So on the left we have, I think it might be the Wangaratta group, and on the right is a Western Health. So they were allowed to go through a process of modifying the clinical pathway to suit what they wanted, ensuring that they retain the clinical criteria, but also to adapt the local empiric guidelines for what their use were. And that actually has been very interesting, the quite wide variability of their empiric therapies, for example, for unknown sepsis, compared to the larger hospitals where they have a higher proportion of cancer patients, for example. The methodology, as I said before, has been very much a shared process through the Better Care project team and the clinicians. But also we've had focus groups, these workshops which are very intensive, focusing on what we needed to do. So the workshops the next workshop will be on sustainability. And these workshops allowed all the sites to come and troubleshoot. They're hosted at different organisations, so they get a sense of ownership for the whole collaboration. It's not just coming out of Royal Melbourne, for example. The local media and branding is critical. Education training, the trainer, we have developed a standardised e-learning program, which is really good. The other thing which is time-consuming but very important during the rollout phase is the actual individualised feedback by sepsis pathways to prescribers, to both nurses and doctors, by the sepsis project person. This is very powerful. So when you have done a sepsis pathway on a patient, you get an email that afternoon or the next day saying, thanks, well done, you've done X, Y and Z, but you've missed X, Y and Z, or thank you for supporting this program. That's very powerful and really leads to quick change and adoption. We've also set up a dedicated EMR working group. It's a new and big issue, I think, nationally about how we manage sepsis through EMR. And I just did want to have a shout out for the Base Camp program, which is from Better Care Victoria, which really is quite an excellent communication tool, both for documents but also for communication. This is a slide of the things that hospitals have done across the state for their sepsis rollout, which is pretty cool. And we're in the middle of this process, so we've got Western Wangaratta Barwon kicking off the last couple of days, and Peninsula is a little bit slow but coming on board. I don't want you to read this too much, but it's a newsletter that Kelly Sykes put together, and it's nice to see that you can see here that 2,412 clinicians have been educated about sepsis, which I thought was pretty impressive. And Swan Hill and Ballarat, you can see, have had some quick wins. And that sense of achievement has really started to change attitudes and change practice. So EMR and non-EMR systems are a major challenge. St John Alert has been, obviously there's been some work in New South Wales about this, but it is an ongoing issue as to what we're going to be doing. Epic, as you know, is coming to the Parkville precinct. ED at RMH did some excellent work with Symphony triggers, although that will be switched off as Epic comes on board. And as I mentioned, we do have a multi-institutional ethics, and I invite any of you in Victoria in particular, if you're interested, to become involved in research, because there will be very granular data coming out from all the sites. I just wanted to finish up with the testimonials, because I think this is where I get the most satisfaction. The increased awareness. As a nurse, I'm much more aware after this project of sepsis, both with patients but also in educating others. It wasn't something we really recognised before. Now everyone knows a pathway, and it doesn't take convincing to use it. Effective communication, it's empowering, it's a great resource, and the consultants like it because patients get recognised earlier. and the consumer. So we have had some great consumers, and this in particular was a mother of a young boy, a 17-year-old son who came in who was very unwell into resus, and she wrote a letter to the Royal Melbourne after the experience where she really could see the impact of the pathway in the care of her son. I'll leave it at that.